good of sharing their knowledge. So, without wasting any further time, I think I will conclude. So, wish you a good hearing. Thank you.
Thank you, Ashwin sir. Actually, we were supposed to do an introduction about Ashwin sir, so those needs no introduction at all. Sir is MD DVD, DNBFRCP. Sir is a professor and HOD of the Department of Dermatology, Government Medical College, Thrissur. Now we'll go on to the scientific session.
Invite Dr. NSF.
Sir, I did invite. Ashwin sir did invite. Sir, I invite you to be the moderator and conduct the.
Yeah, fine. I think we have two speakers, as I already mentioned. The first is talk by Dr. Ashwini, who is an assistant professor in Kottayam Medical College and who has a lot of interest in this field. So I'm very happy to invite Dr. Ashwini to have her talk on introduction, clinical features, mainly like an overview part of it. So, over to you, Dr. Ashwini. I think you can start sharing your screen.
Yes, sir. Thank you.
Thank you.
I hope that is visible. Is the screen visible?
Yes.
And my voice clear? Is it
clear? Welcome.
Okay. So, good evening, all. Let me first of all let me thank. Excuse me. So, first of all, let me thank the organizers of this program, that is IMA Thrissur, the Thrissur Dermatological Society, as well as Thrissur Medical College, for providing me this great opportunity to present before this august audience, and especially a topic of great interest for me, that is leprosy, also known as Hansen's disease. So, at the beginning of this program itself, many were telling that we were organizing this session because it was Leprosy Day on January 30th, or we had observed the leprosy fortnight in Jan first weeks. But is it the real purpose of this session? I would say no. Actually, the real purpose of this session, I would say, is to sensitize ourselves as well as our colleagues about leprosy and the fact that leprosy is there still among us. Okay, and the new cases that were detected in 2019 worldwide was 2.02 lakhs. And you can see that India is still having the greenest color in this map. And India is actually one among the high burden countries for leprosy. And also the grade 2 disability, that is people who present with disability, as well as people who have, or the child cases, pediatric cases of leprosy are also not very less. The importance of grade 2 disability is that when people present with disability, it means that they were not detected early enough to prevent the deformity or disability. And also regarding the pediatric cases, you may be knowing that leprosy is having a very long incubation period, maybe around 5 to 7 years. So if a child is diagnosed with leprosy, that means the child acquired the disease probably during his or her infancy. Okay, and that means the organism is there and the transmission is continuing in a society. And the prevalence rate in India is 0.57 per 10,000 population, and in Kerala it is 0.12 per 10,000 population. So leprosy is a disease which is known from ages, and there are mentions about leprosy even in the religious literature. And that time it was thought that leprosy is a hereditary disease, or it was supposed to be a disease which occurred as a punishment to the sin of people. So because of these beliefs, as well as the deformities and disabilities caused by leprosy, leprosy became synonymous with social stigma. And a person once diagnosed to have leprosy had to isolate himself from the rest of the society. So that person had only three choices. If he was wealthy enough, he could isolate himself in his or her home, or he can get entry into a leprosy sanatorium, which is usually located in a very remote place like a mountain or an island, so that it ensures strict isolation. But the last resort for the poorest of the poor was to somehow survive in this sea of leprosy. And in this, some disturbance. So, as a poor patient, leprosy patient had only such options, and he used to survive by wandering or begging or sometimes stealing. So in this painting, a painting which depicts the medieval times, shows a leprosy patient who is walking in the town of medieval times, and he has a bell in his hand, which is called the leper bell. And he rings this bell so that he announces his own presence in the town. And other people, you can see, they are running away from him out of fear. So the revolution in the field of leprosy happened when the Norwegian scientist Gerard Henrik Hansen discovered the Mycobacterium leprae and said that this is the cause of this disease, and it is an infectious disease. And but the society was not accepting this. Even the medical fraternity were not accepting his theory, and they were laughing at him and his daring prediction. But after this discovery of M. leprae, multiple therapies were being tried, from Cholmugra oil up to even Dapsone, which was introduced in 1949. But soon came Dapsone resistance because of the monotherapy. And in 1982, multi-drug therapy with Dapsone, rifampicin, and clofazimine was launched. So this is a short timeline of how it progressed, or what happened in the field of leprosy in India. So in 1955, I said Dapsone was introduced in 1949. So in 1955, the National Leprosy Control Program was launched with Dapsone monotherapy as the cornerstone. But soon came Dapsone resistance, and multi-drug therapy was introduced in 1982. So we launched National Leprosy Eradication Program with multi-drug therapy as the cornerstone. And this NLEP program happened actually in 2 phases with support from World Bank. And from phase 1 happened from 93 to 2000, and phase 2 from 2001 to 2004. And by 2005 December, we could achieve elimination. Actually, it was a statistical elimination. That is, the target was prevalence rate less than 1 per 10,000 population. So we reached a target of 0.95, so that our country, India, was declared eliminated of leprosy. And after this elimination, all the vertically organized programs were actually disintegrated into the general healthcare system. And what happened? We saw the results. There was an increase in the number of cases. And by 2016, we had to launch Leprosy Case Detection Campaign, or LCDC, which was an active case detection campaign. And under this only, our Ashwamedham and other programs were running. And then in 2017 came Sparsh Leprosy Awareness Campaign. In 2018, Sparsh Leprosy Elimination Campaign. And in 2019 and 2020, because of the increase in childhood cases, this program was integrated with the Rashtriya Bal Swasthya Karikram, or RBSK, and also with RKSK, which deals with adolescents. And this was what was happening in WHO. So now WHO has a global leprosy strategy towards zero leprosy. And this is from 2021 to 2030. So our goal now is to have zero leprosy. And how to attain this goal of zero leprosy? It is by actually early case detection. So let's see what you and me and all of us can do to march towards this goal of zero leprosy. So coming to the clinical features of leprosy, WHO has provided a very simple definition for leprosy, so that even non-dermatologists or even the leprosy workers should be able to diagnose a case of leprosy. These are the 3 cardinal signs identified by WHO. So the first one is a skin lesion. So the normal idea of a person, any person, is that skin lesions in leprosy are always hypopigmented or white patches. It is not always white patches. It can be raised lesions, it can be flat lesions, it can be erythematous or reddish lesions, it can be even nodules. So any skin lesion, but the characteristic feature is the skin lesion should be having a loss of sensation or an impaired sensation. So if you see a skin lesion which is having any skin lesion, any kind of skin lesion for that reason, if it is having a loss of sensation or impairment of sensation, when I say sensation, it is touch, pain, and temperature, you can diagnose it as a case of leprosy. There is no doubt on that, because among these 3 criteria, only one is enough to make a diagnosis of leprosy. So this is the most important criterion as far as doctors in peripheral health centers or peripheral care are concerned. Skin lesion with definite or impaired sensation, definite loss or impairment of sensation. The second criterion is a thickened peripheral nerve. The peripheral nerves can be normally thickened in some cases, like head load workers, there can be great auricular nerve thickening. The right-handers, we can have ulnar nerve thickening. So just thickening is not important, but thickening along with the loss of sensation of the area supplied by that nerve or motor weakness of that muscles of the area of supply. So that is the second criterion, thickened peripheral nerve along with definite loss of sensation or motor weakness. And the third cardinal sign is presence of acid-fast bacilli in the slit skin smear. So this is not biopsy, it is a smear which is taken from the skin. I think you will be having a better idea about these examination as well as the investigations in the coming session. So these are the 3 cardinal signs of leprosy. Anyone, if present, is diagnostic of leprosy. Now a little more in detail about the clinical features. I already said that the incubation period is very long, around 5 to 7 years. And all of us know that this is a droplet infection predominantly. There are other ways of infection which are not very important, but droplet infection is the most important. So the most characteristic thing about leprosy is that whether a person gets a disease or not after getting exposed to Mycobacterium leprae depends on the immunity of the person. When I say immunity, it is the specific cell-mediated immunity to M. leprae. So an HIV positive patient or a patient on immunosuppressive agents like steroids are not at an increased risk of getting leprosy. That is obvious because we are not seeing an increase in case of leprosy with increase in HIV cases. So it is the specific cell-mediated immunity of one individual to M. leprae that is important. So based on that, the person may get a disease or may not get a disease when he is exposed to M. leprae. And if he gets the disease, whether he gets what kind of a disease he gets, again depends on the specific cell-mediated immunity. If that person is having a very good CMI, he gets a tuberculoid kind of leprosy. If the immunity is low or nil, he gets a lepromatous kind of leprosy. And the tuberculoid leprosy is supposed to be, and tuberculoid as well as lepromatous leprosy on either side are supposed to be immunologically stable. Whereas the people who have an immunity in between, they develop something called borderline leprosy and they have a fluctuating immunity. So we have mid-borderline or BB at the center. Towards tuberculoid, you have BT or borderline tuberculoid. Towards LL, you have borderline lepromatous. So together we have 5 types: TT, BT, BB, BL, and LL. And TT, LL are supposed to be immunologically stable in simple terms. There are more complex things on that, but for simple understanding, TT as well as LL are immunologically stable, whereas BT, BB, BL are not immunologically stable. They have a fluctuating immunity, so that if the immunity drops down, BT person can go down to BL, or if the immunity improves, the BL person can improve to BT. So this classification of TT, BT, BB, BL, and LL is what is called Ridley-Joplin classification. So this Ridley-Joplin classification is based on 4 criteria. One is clinical criteria, so how the lesion looks like. Second thing is bacteriological, that is, we take a slit skin smear, as I mentioned earlier. Based on if we see bacilli or not, we decide the bacteriological criteria. Third one is histopathology. We take a biopsy and we observe for the histopathological changes, and based on that also you can differentiate. Fourth point is immunological, which is basically a lepromin test, which is actually not being done now. But again, that is one of the criteria which was used for Ridley-Joplin classification. So now imagine a person, I'm going to tell you about tuberculoid leprosy. So imagine a person who is having a very good cell-mediated immunity, specific cell-mediated immunity to in that patient, when M. leprae enters his body or the person gets exposed to M. leprae, he's having a very good cell-mediated immunity. So what happens? You all know it is a granulomatous disease. So there is a well-defined granulomatous response or very good granulomatous response which is happening. So the lesion become a raised lesion. And also the good granulomatous response destroys the small nerve pits on that area, as well as destroys the hair and also the autonomic nerve fibers. So what happens? Ultimately, there will be a raised lesion with absence of sensation, absence of hair, and absence of sweating because of loss of autonomic nerve fibers. And regarding the nerves may be thickened, 1 or 2, very small, only less number of nerves will be thickened in tuberculosis. This is because the good CMI is able to confine the whole of the bacilli into one single point. So you get a single lesion or 1 or 2 lesion and a single nerve or 1 or 2 nerves. So the number of nerves and the number of lesions will be less in tuberculoid leprosy, but those lesions will have loss of sensation, loss of hair, and loss of sweating, and they all will be raised lesions. And when you take a histopathology, you can see that it is a well-defined granuloma. Because of the high CMI, the granuloma will be well-defined. And you take a smear, because the granuloma is there, the bacilli have already been destroyed, so the smear is not expected to be positive, it will be mostly negative. And lepromin test, because CMI is very high, lepromin is just like our tuberculin test. So because the CMI is high, you expect a positive lepromin test here. So that is about tuberculoid leprosy. And coming to lepromatous end, what happens? Unlike tuberculoid, where you had a very good CMI, in lepromatous, the CMI is very, very low, or even it may be nil. So that the bacilli cannot be confined to that single point, but the bacilli disseminates throughout the body. So that there will be symmetrically arranged lesions throughout the body. And because CMI is low, granulomatous response will not be that good. So that the lesions may not become raised, but they become flat. So flat lesions, again, granuloma is not that good. So sensation, the nerve twigs may not be destroyed. So the sensation will be intact. Hair will be normal because again, hair follicles are not destroyed by the granuloma. The autonomic nerve fibers are also not affected. So the sweating will be normal. So you get multiple symmetrically arranged, usually flat lesions, which have normal sensation, normal hair, and normal sweating. But in addition, you will find some other lesions, like you may have infiltration of the face and the earlobe. You may have infiltration of the eyebrows leading to medrosis. You may have patchy anesthesia of the hands and feet, just like the diabetic neuropathy, but there are differences. And also coming to the nerve, it will be bilaterally symmetrically thickened, not like in your tuberculoid where 1 or 2 nerves were asymmetrically thickened. Here it will be bilaterally symmetrically thickened. So the raised nature of the lesion and the loss of sensation, loss of hair, and loss of sweating decreases as you go towards lepromatous. That means it becomes more and more flatter with retaining of sensation, hair, and sweating. And the number of lesions also increases as you go towards lepromatous. Same thing with nerve. Number of nerves increase with as you go towards lepromatous. Now the histopathology, the granuloma becomes ill-defined because it is lepromatous, CMI is very low. You can also see a gran zone. When you take a smear, you can see bacilli in the acid-fast bacilli in the smear. And in LL cases, you can see even bacilli in the normal looking skin, not only in the lesion. And lepromin test, CMI is low, so lepromin is supposed to be negative. So this is the overview. Now we'll see the pictures of the lesions. See, this is a boy who has a very well-defined plaque or raised lesion. There is no hair on the lesion. It is completely anesthetic. There is no sweating on the lesion. So this is probably a case of HDTT, the extreme end of tuberculoid leprosy. Now coming to this case, see there is a plaque or a raised lesion, but you can see a few lesions which are nearby, smaller lesions. That means the body is trying to confine everything to a single point, but it is not successful, so that there is spillover to small lesions nearby. These lesions are called satellite lesions, and this happens in BT. BT means a little immunity less than TT. So the patient does not have the good immunity as good as TT, but a little less immunity, so that the CMI is trying to confine everything into one point, but not successful, so that you develop satellite lesions as well. So this is BT. Now, this is the LL, lepromatous leprosy I was mentioning. See, you can see symmetrically distributed flat lesions with sensory sensation intact. So here you have to note one point. Leprosy can even present with lesions with normal sensation. So lepromatous leprosy, sensory loss may be, sensation may be intact. But the thing is, lepromatous leprosy is the leprosy which is more infective, whereas tuberculoid is not that infective, and lepromatous is more infective, but the skin lesions do not have sensory loss as in tuberculoid. So there is a high chance that these cases can be missed. And in the right-hand side, you can also see the earlobe infiltration. And this is the facial infiltration associated with lepromatous leprosy. See here, you can see that both the pictures, the patient is not having eyebrows. There are infiltrates on the face, on the earlobes, and this is called leonine facies. And here, this is a more advanced case. You can see the sunken nose deformity. There can be loosening of the alveolar processes, loosening of the front teeth on the front, like incisors, because of the loosening of the alveolar processes. And also you can see ulnar claw hand. So, and again, madrosis. So this is a very advanced case. Nowadays, we don't see any such cases because of the early diagnosis and treatment. And lepromatous leprosy people will also have anesthesia of the hands and feet. It is called glove and stocking, but it is not truly glove and stocking. You can have patchy areas, you cannot identify a true cutoff or true area for that. You can have patchy anesthesia on the hands as well as feet. The complication associated with this is trophic ulcer. And because there is anesthesia, person continues to use the limb without any botheration, and this ulcer becomes chronic and adds on to the deformity or disability. Now, these are certain lesions which are seen in the borderline spectrum. Just for completion's sake, these are called punched out lesions or Swiss cheese lesions. And this is an inverted saucer-shaped lesion. Such lesions, geographic lesion, multiple. There are many kinds of lesions seen in borderline lepromatous leprosy. I mean, not borderline lepromatous, borderline leprosy, including BT, BB, and BL. So now this is important. This is called indeterminate leprosy. So till now I was speaking about TT, BT, BB, BL, and LL. But sometimes leprosy we may not be able to categorize a person into any of these categories. And then we call it indeterminate. Even we may not be able to diagnose it as a case of leprosy. So this usually occurs in children, usually seen as a hypopigmented macule on the face of a child, very ill-defined macule. The good thing is that many of the cases, around 70%, can resolve spontaneously. But 30% of the children can enter into one of the spectrum. There may not be any sensory loss associated with the lesion. Just you see the lesion, nerves will be normal. Even if you take a smear may be negative, and biopsy also may not yield any positive result. So follow-up is very, very important in such cases. We cannot always treat a case without confirming because of the social stigma. So in such cases, follow-up is very, very essentially. And this is another case of leprosy, which is not usually coming directly to dermatologist, but usually coming via orthopedician or via neurologist. So this satisfies the second criteria I was telling. The thickened peripheral nerve with sensory or motor weakness associated with that nerve. There is no skin lesion at all. So skin is not involved, only the nerve is involved. So this is called pure neurotic leprosy. Again, this is not a very rare condition. It is seen in India. So these are rare conditions. So let us now see what is not leprosy. So since I have mentioned many skin lesions and many of most of the types of skin lesions have been mentioned, like flat lesion, raised lesion, nodules, everything I have mentioned. So you may be thinking any skin lesion we see may be leprosy. You must have that high degree of suspicion, but there are some skin lesions which are not leprosy. One, this is Ptasis alba. This many of us are familiar with. This is actually the condition which most of the parents take the children telling vitamin deficiency. They get hypopigmented or whitish patches on the face, multiple patches, oval patches. Usually they have an atopic background like allergy to dust, allergy to cold and all. And this keeps on recurring, especially in winter. And it subsides on its own. And this is actually a kind of eczema, endogenous eczema. You may get a scaly lesion before. Later on, it becomes hypopigmented like this. So again, on follow-up, you can see that these are subsiding by itself. So Ptasis alba is a benign condition which is self-limiting, which can be which can be mistaken for leprosy or vice versa. Second, this is Ptasis or Teenia versicolor. Again, what you call chudanga or temal in Malayalam. So this is again hypopigmented flat lesion seen usually on the upper part of the body, trunk, shoulder, upper back, and in children you can also see on the faces. These are actually caused by some fungi which are in normal flora of our skin. So they are actually lipophilic fungi. They tend to have an affinity towards the sebaceous glands. So they are more folliculotropic. They are seen around the follicles or on the areas of the skin where there is sebum secretion more, like the upper trunk, the shoulder and all. So you see asymptomatic hypopigmented macules. One thing you can see is that you can see multiple macules which coalesce together, and multiple, when they coalesce, they have a polycyclic border. I think you can see in the picture, there will be a polycyclic border in the periphery. And this can be easily treated with antifungals. Third differential diagnosis, common condition is vitiligo. Vitiligo, it will be papery white, not hypopigmented. It will be papery white because it is an autoimmune destruction of the melanocytes. So completely there are no melanocytes in that area. So it will be completely white, papery white, and you can also see white hair on this lesion. So if you see white hair or leukotrichia, it is in favor of vitiligo. And this is Teenia corporis or dermatophytosis. The classical differentiating feature between these two is this will be pruritic or itchy. So here you see annular lesions or raised lesions with a peripheral activity and central clearing. And patient will have intense pruritus or itching, so that you can easily differentiate this from a case of leprosy. So to conclude, itching and scaling are not usually features of leprosy. I would say itching is never a feature, and scaling is not usually a feature of leprosy except in a scenario which I'll be discussing now. So coming to Lepra reactions. So Lepra reactions means normally it is a very uneven full course for leprosy. But sometimes in between there can be some immunologically mediated episodes of either it can be an acute episode of inflammation or subacute episode, which can happen during the uneven full course of leprosy. That is called Lepra reaction. So it can happen in two ways, type 1 Lepra reaction or type 2 Lepra reaction. So when you say type 1 Lepra reaction, I mentioned earlier that we have three entities in between called BB, BT, and BL. So these have these three have fluctuating immunity. So borderline leprosy, they have fluctuating immunity. So when a BT person gets a dip in immunity, BT person can go down to BL. Again, a BL person, when he has an improvement in immunity, he can go to BT. So this is basically what happens in type 1 lepra reaction. See, in this picture, you can see the left-hand side lesion, actually it is not visible. Actually, there is a faint lesion on the forearm in the first picture. But in the second picture, you can see that that lesion is becoming inflamed. So exaggerated inflammation of an existing skin lesion. And after a few days, it will subside with scaling. So there will be erythema, edema, tenderness, and subsides with scaling. Again, the same thing can happen with nerves also. An existing nerve which was thickened can become painful. It can become tender, even it can develop a nerve abscess, which is actually an emergency. And this may be associated with edema of hands and feet. So exaggerated inflammation of whatever was existing. So this may be sometimes the first presentation of the person because they may have neglected the previous skin lesion. And the complication with type 1 lepra reaction is if they develop sudden nerve tenderness, neuritis, they can go in for sudden palsy. Like if it is ulnar nerve, claw hand, foot drop, and even cranial nerve facial palsy can also develop following type 1 reaction, especially if there is a lesion on the face. That is type 1 reaction. Now coming to type 2 lepra reaction. Type 2 lepra reaction is basically a type 3 hypersensitivity. So by type 3, what we mean is immune complex mediated hypersensitivity. So when it is immune complex, we need to have a high antigen load. So this happens in people with high bacillary load, that is lepromatous leprosy. And because it is immune complex, it is not restricted to the lesions or the nerves like in type 1 reaction, but this is a whole body process. So the person will have constitutional features like fever, myalgia, malaise and all. Along with that, they will have crops of lesions, and these lesions are called erythema nodosum leprosum. So they are actually subcutaneous tender nodules which occur in crops on the face or on the hands towards the evening hours. And it subsides in 2 to 3 days. Again, another crop comes along with constitutional features. And it can affect other organ systems as well because, again, it is an immune complex disease. So the immune complex can get deposited in different parts of the body. It can cause uveitis, iridocyclitis. It can cause arthritis, dactylitis, glomerulonephritis, even epidermoorchitis. So both type 1 and type 2 reaction, one thing to remember, never stop MDT. And you have to continue other management. The most important advice you can give is just give an idea about the clinical features of the reactions and ask them to seek medical help whenever if they come across such a manifestation, and to continue MDT. Rest of the management will be dealt with in the coming session. So with this, I am concluding my talk. So the take-home message is, the delay in diagnosis is what leads to the disability and deformities associated with leprosy, which in turn leads to the social stigma. And our aim is 0 leprosy, 0 disability, 0 child cases, and 0 stigma. And the key to, or the answer to all these is only one thing, that is early diagnosis and treatment. So with early diagnosis and treatment, that is with an appropriate therapy as well as at appropriate time and adequate duration, any person can live a dignified and normal life like any other person. So hate leprosy and not the patient. Thank you.
Thank you, Ashwini, for that very clear and crisp presentation. That is what we wanted from you, to set the stage for the further. Actually, I did not tell that earlier, but there are people even now who are asking, is leprosy still a problem? Should we discuss about leprosy? So that is a question that we face occasionally. The answer to it is that if you go through the statistics, you can find that though the prevalence has come down a lot, but that is mostly a result of the change in the treatment duration. Because earlier, all the people were on the list because the treatment was for several years and sometimes lifelong earlier. So now the fixed duration therapy has ensured that there are fewer people at any point of time on the list. If you go through the annual new case detection rate it has been remaining steady. It is something of a worrying factor for all of us for the last 20 years or so. There is no significant change in India. So that means transmission is still happening. So that if anyone has a doubt why we are discussing now, that is the reason, because the new case detection has the rate is still remaining the same, and we have also have a very ambitious target of entirely eliminating leprosy, not only the statistical term but absolutely eliminating zero leprosy. That is why we are discussing it. So you have clearly given something for everyone, because we have a group where all doctors from different branches are here. So many of they may be aware of this, but some in their practice they may not be seeing leprosy for some time. So it was a good refreshing for everyone. So that way it is well presented. We will have any questions or discussion later on. I think I request you to stay still stay on live and be on the web. That is it. So we go to the next talk. That is by Dr. Binesh VG, who is okay. Dr. Ashwini, you have stopped sharing?
I'll stop.
Okay. So that is by Dr. Binesh VG, who is an associate professor in Thrissur Medical College. And he will be talking on the other aspects, the confirmation, the clinical diagnosis has been dealt with. So how to confirm it further? What are the tests that are available? How to interpret it? In a nutshell, I think he will be discussing. And again, the current situation treatment, how to treat, and what are the important things in the prevention part. So all this will be covered by my colleague, Dr. Binesh. Over to Dr. Binesh. You can start sharing your screen and go on with the presentation.
Okay, thank you. So, good evening all. First of all, I would like to thank the organizers, the IMA Thrissur branch and Dermatology Club Thrissur for giving me this opportunity. And I'll be talking about an approach to the diagnosis, treatment, and prevention of Hansen's disease. And what my aim is to just share with you some of the basic aspects of this diagnosis and treatment. And also, I think that will be helpful to you. And also, I may be just like the fine sensation, just like we test the fine sensation, I'll be finally touching some of the recent aspects or some of the recent aspects only. So I'll be covering this topic in these headings. First of all, I'll be talking about the diagnosis, which include a clinical examination, which in turn consists of examination of the skin lesions and nerve function assessment, and investigations. I will just touching upon the investigations, and regarding the treatment of the disease and reactions, and also the prevention of disability. This is how I am going to deliver this topic. Now, first of all, coming to the diagnosis, I think this part has been dealt by Ashwini already. So suppose a patient like this is coming to you, or you suspect a case or a skin lesion as Hansen's disease, what to do? The first you think.
Sorry to interrupt, Dr. Binesh. There is a request from one of the participants. If you can increase the volume somehow.
Sir, it's actually, I think it's a maximum.
Not all right, but if you can, by any way, you can try that. Otherwise, you can continue.
Okay, sir. Actually, I think it's the maximum volume.
Okay, fine. Continue.
Okay. So the first cardinal feature is the definite loss of sensation in a hypopigmented or reddish or even a coppery or erythematous skin lesions. So which are the sensations that is lost? That include a fine touch, pain, and temperature. And remember, this can be just an inability to discriminate between the hot and cold sensation, which may be lost first in case of Hansen's disease. So be careful. You may have to always check all these sensations. And
Can you come closer to the mic by any method? Is it possible?
So now, is it okay now?
Yeah, it will be better. You can try. Continue.
Okay. So usually what we do is to, for testing the fine touch sensation, we use a cotton base. But if you go through many of the modules, training modules, they don't advise a cotton base because sometimes even on a normal skin, it may be difficult to get a, even it may not be able to appreciate even in a normal skin, like even on the soles. So most of the training modules, they recommend a ballpoint pen. The weight of a ballpoint pen can be used to test for the fine touch sensation. And there is another one. I want to tell about this thing, Weinstein monofilament, which has been, this will make it more standardized because here there are different filaments where the pressure exerted can be standardized. So filaments of different strengths are available. So what is recommended is the 10 gram for the foot and 2 gram for the hand. We have to just apply the pressure just to bend that filament. So that means it will be standardized for all patients and different areas also. Okay. So we have dealt with one cardinal sign. So next, remember the diagnosis of Hansen is one thing is mainly it is clinically, and it may be aided by the lab investigations. So the two cardinal signs are purely clinical. So the first one is over. The second one is the involvement of the peripheral nerves in the form of definite thickening and a thickened or enlarged peripheral nerve with loss of sensation and or weakness of the muscle supplied by that nerve. Okay. So that examination of the nerve include palpation of the nerve. That may be to diagnose the Hansen disease initially. And also you may have to do the sensory test and also the voluntary muscle testing for the nerves. So let us see how to palpate the nerve. First of all, the positioning of the patient is important. I will talk about which are the nerves to be examined in the next slide, and we have to locate the nerve correctly. And it is a must that whenever you palpate the nerve, always examine the patient face. We have to see whether the patient winces with pain or not. That is how we know whether the nerve is tender or not. So what we have to assess is whether the nerve is thickened, whether the nerve is tender. And always use the pulps of the two fingers, the index finger and the middle finger. And you can just trace upwards and downwards along the course of the nerve to see any irregularity also. So these are the main nerve trunks which are examined. The radial nerve, the radial group, ulnar nerve in the ulnar group, median nerve in the wrist, then common peroneal nerve, and the posterior tibial nerve. These are the main nerve trunks which are examined, and also the facial nerve. Okay. So we have palpated the nerves. Then next is to assess the loss of function. We have to assess loss of function. Function means the sensory impairment and motor function. Remember, whenever you examine a patient with Hansen's disease, always it is mandatory to examine the eyes, you examine the hands, and examine the feet. So that makes almost 90% will be over by that. So for sensory test, we are not, it is especially in a peripheral setup, I think it is better to follow these tips. You can examine, what we have to examine is on the upper limb. We have to examine for median nerve, ulnar nerve, and radial nerve. So for the sensory function of these three nerves, we examine all the palms and also the dorsal aspect also. And these are the points where you can examine for sensations. This is about 1 to 2 centimeters from this crease, and this point may be 1 to 2 centimeters from the basal crease of the thumb. This may be 3 to 4 centimeters from down the hypothenar eminence. We can see another point on this metacarpal head, and also on the pulp of the fingers. Similarly, on the feet, we can again examine the pulp of the toes and on this metatarsal heads and on the center of the heel. Again, we can use either a cotton wisp, a ballpoint pen, or a Weinstein filament, whichever is available. So we have assessed the sensation. Next is we have to test for the muscle function. We have to see whether the muscle is, this is a very simple classification where we classify the muscles, the strength of the muscle into strong, weak, and paralyzed. Strong means the patient is able to perform the movements against resistance. Weak means there is some weakness. The patient is not able to perform the movement against the resistance. And paralyzed means not at all able to perform the movement. And this is a comparison between the Medical Research Council grading and the simple scale. You can see that strong correspond to 4 and 5, weak correspond to 2 and 3, and paralyzed correspond to 1 and 0 of the Medical Research Council scale. And now let us again, where we are going to assess the voluntary muscle testing. One on the eye, second on the hand, third on the feet. You have to assess it on each eye, each hand, and each feet. So on the face, you are going to assess the facial nerve. So we are not going to do every test for the facial nerve. Just the main nerve which is affected is the zygomatic branch. So what we have to do is ask the patient to close the eye and try to pull down the lid downwards and see whether there is any weakness. If there is, record it for both eyes. Next is on the hand. On the hand, which are the nerves? They are ulnar, median, and radial nerve. For testing ulnar nerve, only one function we are going to assess. That is, ask the patient to just abduct with the little finger and apply pressure at the base of the finger. That test is enough. And for median, again, the abduction of the thumb is tested. Either the patient can place the thumb flat on the table and raise it on the 90-degree angle to the palm, and you can exert the pressure against it, or the patient can stretch the forearm and ask him to point the thumb towards the nose. Then it will be in the abduction. Again, apply pressure to see whether the movement is possible against resistance. So these are simple tests by which we can assess the nerve function. And for radial nerve, the wrist drop. So ask the patient to dorsiflex the wrist and apply pressure downwards and look for any resistance, any weakness. For common peroneal nerve or lateral popliteal nerve, the foot drop. Ask the patient to dorsiflex the foot, press the foot downwards, and assess the muscle strength. And for the posterior tibial nerve, see whether there is any clawing of the toes. So we have done a sensory test for the nerves and also voluntary muscle testing. All these we have to record. And why this is important, assessment of this nerve function is important. One is, we have already mentioned it, to diagnose leprosy. Once we diagnose leprosy, again, we have to perform it at least every 3 months. Why? We may come across some nerve function impairment. If we come across some nerve function impairment, we have to treat it and to monitor the response to treatment. For that also, we have to do this nerve function assessment. And why we are doing it, this is the main aim, is to prevent the most dreaded complication, the disability and deformity, which may lead to a social stigma. So it is mandatory that we have to do this voluntary muscle testing, sensory testing, or this nerve function assessment every 3 months. And if there is a neuritis occurring in a patient and the patient is on treatment with steroid, then it has to be done every 2 weeks. Once the steroid is stopped, we have to do it every month in such a case. So this has to be done frequently, and this has to be recorded also. Now, coming to the disability and deformity. What is a disability? Disability means lack of the ability to perform an activity, and deformity is the visible consequence of that impairment. And there is a scale, a disability adjusted life year, DALY, the number of years lost due to ill health, disability, or early death. And studies have shown that persons affected with leprosy have lost 13.4 years average from the productive working period of their life, almost constitute about 30% of their life. See how sad it is. So why this deformity occurs? The main cause of this deformity is the nerve damage. So the nerve damage will lead to loss of sensation, and it may lead to injury, either an injury or due to an injury due to pressure also. All this will later on lead to an ulcer formation. And there is a lot of loss of motor function, which again will lead to weakness and contracture. So along with this, there can be involvement of the autonomic nerves also. So there will be loss of setting, it will lead to dryness, there will be cracking, fissuring, infection, and ulceration. Okay. So in that way, the nerve damage, so our prime aim is to prevent this nerve damage occurring. And remember, reactions are one of the most important part of the disease, which can lead to this nerve damage. And in the eye, what we are told is already told is about the process of deformity in the hands and feet. And in the eye, again, there is affection of that zygomatic branch of the facial nerve. So it will lead to lack of thalamus. And there will be an exposure keratitis, corneal ulcer, and opacity, leading to blindness. Trigeminal nerve can also be affected. It will lead to corneal anesthesia and corneal ulcer and blindness. Okay. So these are the pictures of some of the deformities that has already occurred in patients. This is an ulnar claw hand. This is a total claw hand due to the involvement of the median and ulnar. So wrist drop due to involvement of the radial nerve. The foot drop and the claw toss, the exposure, the lack of thalamus due to leading to exposure keratitis, corneal ulcer, can see the redness of the eye. So these are the things we have to look for when the patient comes. Always look into the eye, examine the hand, examine the feet. So after completing this, we have done a sensory test, we have done a voluntary muscle test. So after doing that, we can do it on the eyes, we have done it on the hands and feet. Now we can grade if the deformity, if there is. For the hands and feet, the grading of the deformity is the same. It's similar. So when there's a sensory, when the sensations and the muscle power are normal, the grade is 0. When only sensation is lost, then the grade is grade 1 disability. When muscle power is affected, there is muscle weakness or paralyzed, then it is grade 3. It is grade 2, irrespective of the sensation. Okay. So this is same for the hand, and so we have to assess in each hand and each feet, we have to record it. This is the grading on the eyes. In the eyes, again, if the vision is normal and the blinking is present, there is no lid gap, that means there is no disability. So it's grade 0. But when there is vision is affected, so that is a sensory testing. When the vision is affected, cannot count fingers at 6-7, maybe due to that corneal ulcer. Or if there is muscle weakness leading to gaps between the eyelids, corneal ulceration and red eye, corneal opacity. So all these are the deformity that deformities can occur in the eye. So the grade is 2 there. So you can see that in the eyes either 0 or 2 is there. Okay. If there is a disability, it is grade 2. So we have to calculate this. You can see that there are 6 areas: 2 eyes, 2 hands, 2 feet. The maximum score is 2. So the maximum total score can be 12. So it ranges between 0 and 12. This we have to record frequently. Now we have covered the 2 cardinal signs: the sensory testing, on the patch we have done, and the assessment of the nerve function also done. Nerve palpation, sensory testing of the nerve, and voluntary muscle testing of the nerve, that is done. Now coming to third cardinal feature, that is a slit skin smear. If the smear is positive, then again that itself is diagnostic of Hansen's disease. It can be a solid, fragmented, or granular bacilli. And we always do skin biopsy to confirm the diagnosis. In an institution, I think it's always better. And I feel it is always better to do a skin biopsy in all patients. Leprosy is a disease which has got a lot of social issues. We have to give treatment for a longer period. The drugs can produce side effects. So I think it is always better to go for a skin biopsy to confirm the diagnosis. And there are other tests. There are a lot of research is taking place in this area. Still, we are lacking point of care test to diagnose the Hansen's. ELISA or the PCR test are there actually. And actually, we haven't got a clear advantage of this test. And ultrasound of the nerve is high resolution ultrasound. We have done a study in our institution that can help. Remember, this cannot replace our clinical assessment. It can actually, and it's an additional tool which can help in the diagnosis. And we have found that this high resolution ultrasound has detected, it can detect the cross-sectional area, the vascularity and echo texture of the nerve. And it was able to pick up some of the nerves which was not thickened clinically. So it has got an advantage. Okay, but remember, it cannot replace the clinical examination as of now. Now coming to the treatment, this Ashwini has already mentioned, I think. There has been, I'm talking about the newer change in the WHO classification. Now, the paucibacillary includes those patients with the 1 to 5 skin lesion only. More than 6 skin lesion, if there is even a single nerve trunk involvement, they specify that it's a nerve trunk involvement, not the cutaneous nerves. In 1 or 2 of those WHO modules, they have mentioned that it should be nerve trunks. And presence of acid fast bacilli. These are the multibacillary cases. And there has been a change from this again a WHO. I think NLP hasn't started following this. Here also there's a change. Initially, we were giving only 2 drugs for paucibacillary, rifampicin and dapsone only. Now the WHO recommend 3 drug regimen, like rifampicin, dapsone, and clofazimine. So we give it the same regimen for 6 months in paucibacillary cases and 12 months in multibacillary cases. Okay. So that has been a recent change. Now coming to the reactions, management of the reactions. There are type 1 and type 2 reactions. Remember, when the reaction is mild, whether it is type 1 or type 2, we can advise the patient rest, or try to find out the precipitating factor. And we can try to manage it with some analgesics like paracetamol or some anti-inflammatory agents like ibuprofen, etc. And when the reaction is severe, if it is type 1 reaction is severe, or if there is neuritis either in type 1 or type 2 reaction. If there are signs of neuritis, always it is better to use a steroid. And this is the regimen recommended. Usually we start with the 40 to 60 milligram, and it is tapered over a period of almost 20 weeks. You can see that when the 40 milligram is started, we give 40 milligram for 2 weeks, then 30 milligram for 2 weeks, then 20 milligram for about 8 weeks, then again 10 for 4 weeks, and 5 milligram for 4 weeks. Okay. But when it is 30 milligram is started, it is 30 then 25. When it reaches 20, again it is 8 weeks. Okay. The recommendation is like that. And in type 2 reaction, there are certain additional agents like clofazimine, which we can add. If there is a severe reaction, we can add clofazimine along with steroid. This is the dosage. And it is not high dose clofazimine is not given for more than 12 months. When it is only skin lesions, EN lesions only, when it is severe, thalidomide is a drug of choice. The other agents include pentoxifylline, methotrexate, cyclosporin, and azathioprine. And newer biologicals are also being tested in managing type 2 lepra reaction. Now coming to the disability management. What is a plantar ulcer? Whenever there is an ulcer, our main aim is to prevent it. We always be careful to prevent the formation of an ulcer. But if the patient develops an ulcer, yes, give adequate rest. It can be a bed rest, use splints, crutches, and always advise a standard footwear. An MCR footwear will be ideal. And good wound environment is important. Tell about the hygiene and protection of the wounds. And there is a disability prevention and medical rehabilitative DPMR program. The aim of this program is to prevent the occurrence of any disability or deformity and prevent the worsening of if it occurs, then we have to prevent the worsening of this disability or deformity. Oh, the most important thing in this disability prevention is early detection and diagnosis. And once the diagnosis is made, we have to do adequate counseling regarding signs and symptoms of reaction. Remember, type 1, the reactions are one of the most important cause for neuritis and the subsequent deformities. And again, the patient should report immediately in such situation. And the early diagnosis of the reaction, and remember, assessment of the nerve function is important. Always do the sensory testing and voluntary muscle testing in the frequency, as I have already mentioned it. And we have to manage. Once the neuritis, if there is neuritis, it's always better to start the patients on steroids. Remember, it should be started early. It is recommended that it should be an early loss. That means before 6 months. If it is more than 6 months or more than 1 year, there may be that neuritis may become irreversible. And demonstration, this is one of the important things. We have to address the patient regarding some self-care practices. This I will tell you what are those. And we have to give active and passive exercises for the paralyzed or weak muscles. Now this is about the self-care practices. This is very, very important. I'll be talking about the hands and feet and also the eyes. So for the hands, the patient should always check or inspect the hands for the wounds or redness, and always soak the hands in water. And if there is a hard skin, should be scraped away using some pumice stone. And this is important. Don't go do any dangerous things, like don't go near the fire, and always use some protection when holding these utensils, especially with heat. And in the workplace also, we have to modify these instruments like this. The rough handles, thorns, hammers, etc. They may produce harmful effects. So make the handles smooth, put padding on the handles, use gloves. And when the nail is, we have to use pliers. Don't hold the nails. And feet, the patient has to inspect the feet every day. So it's a mirror, can inspect the feet and also inspect the footwear. Look for any sharp objects in that. And if there is a wound or impetigo, if there is erythema or blister formation, all those things should be looked for. And the feet care includes soaking the feet about 20 minutes in lukewarm water. Again, the hard skin can be scraped away using some pumice stone, and use moisturizers in both hands and feet. Regular use of moisturizing agent is important. because there is dryness, cracking, fissuring, all those kinds of it. And checking the fit is important. Now coming to the eyes, never let dust enter into the eye. When a situation like this occurs, close the eye or use protection using either goggles, hat, or even the clothes. And while sleeping also, the patient has to passively close the eye or use blanket or cloth to cover the eye, use a mosquito net. Never let these things to enter into the eyes. Rubbing of the eye is dangerous, and hold the eyelid always to close the eye. Check the eye regularly, just like the hand. Check the eye regularly, look for any warning signs, and discuss it with the health worker or doctor. Suppose some dirt, etc. enters, then clear away with the dirt with a clean cloth and use eye drops. So that is regarding the self-care practices. Now coming to the prevention of Hansen. There are two methods of preventing Hansen. One thing we can use a chemoprophylaxis, second thing vaccines. So WHO has advised a single dose rifampicin. This can be given for the patients and also for the household contacts. And also other contacts in the community also. The rifampicin is given as a 600 milligram single dose. Immunoprophylaxis with vaccines. BCG is, there are a lot of studies with the BCG. It has been proved to be effective in conferring immunity in leprosy. And also, SDR, the single dose rifampicin is given along with the BCG. It is going to be more effective. BCG revaccination is, the effect is unclear. And this is another vaccine which has been developed in India, Mycobacterium indicum prani, in preventing MIP vaccine. It was available as Immuvac, Lepravac, etc. And the availability is one of the problems. And remember, now also there are a lot of research is taking place in the field of diagnosis of Hansen. We are looking for more tests which can accurately diagnose it. Some biomarkers again for monitoring the patients, and also regarding leprosy treatment, different regimens and antimicrobial resistance surveillance. Then regarding the prevention of leprosy, alternatives to single dose rifampicin, and the giving chemoprophylaxis to all the patients, all the persons without doing a contact tracing. That is to avoid stigma for giving prophylaxis, chemoprophylaxis. So these are the things that are being taken place. And also vaccines. There is a tetravalent vaccine now with the recombinant vaccine like Lepravac. So there are different that research is taking place in that field also. So to conclude, yeah, we establish the clinical diagnosis of diagnosis of Hansen's disease by clinical methods and investigations. And once we diagnose, proper counseling regarding the disease process, reaction, the drugs, their side effects, and the duration, and also regarding the deformities, the prevention of the deformities and self-care practices are important. We have to do frequent assessment of the nerve function, and it is important to detect and treat the deformities early. So thank you for the patient listening.
Thank you, Binesh. I think it was a very practical session. A lot of take-home messages for everyone. You touched upon a very important aspect of leprosy, which is very important, because earlier it was always in the last few decades, it was the major challenge was to case detection, identify cases, and put as many patients on MDT. That was the main objective of our entire mission. But now, since that the number of cases have come down, now our target is very high also, zero leprosy. So now is the time when we have to continue the case detection, of course, but we have to address to the issues of the patients. Many of them are having deformities, so how to prevent them, because that makes a lot of difference to their life. So that in that way, this was a very practical session. So I'm sure you have answered many of the doubts of the participants actually. But anyone have any doubts can put it in the chat box, and we'll see whether we can address them. Just before, as an introduction, I will also tell that our theme this year was Be United for Dignity for leprosy patients. That was our theme for this year's Leprosy Day. So the dignity part is has been given a lot of emphasis this year. For that dignity, people have to have fewer deformities. So that is very important. If there are any questions, you can put in the chat box. I can ask to the both the speakers.
So shall I stop the slide share now?
Yeah, you can.
Yeah,
yeah.
Or by the time someone asks a question, I think shall I start with Dr. Ashwini? If you can unmute.
Yes, sir. Yes, sure, sir.
Yeah. So, what do you think is the actual our current challenge now in achieving these zero targets? Zero target is, as you correctly mentioned, zero disease, zero disability, and zero stigma, isn't it? So, what do you find are the main challenges now to achieve these targets?
Sir, I think it is the problem with the case detection only, because with any other skin condition, people, they self-report. But with leprosy, we don't see that much of self-reporting, maybe because the lesions are asymptomatic. And only when they have some sort of neuropathy or some disability, they tend to seek medical attention. So I think we'll have to go back to active case detection in order to find out the cases which are hidden in the society. The higher disability rate as well as the child cases actually point towards the fact that we are seeing only the tip of the iceberg. So there are a lot of cases which are hidden in the society. If we go for an active case detection, I'm very sure we'll be finding out a lot of cases, and this will not be the statistics we have. So I think that is the major challenge, and social stigma is one reason for the less number of detection. Actually, people, even if they have a lesion which they may think leprosy, also they may be reluctant to come to the dermatologist and get a diagnosis of leprosy.
Can you say something about the how multidisciplinary our approach should be? Because both of your talks covered many aspects about the involvement of various systems, be it nerves, be it bones, be it the eyes, isn't it? So can you tell Dr. Ashwini, can you tell something about how important it is to have a multidisciplinary approach to the management of Hansen disease? Especially, again, I am telling in this current stage of the leprosy elimination program.
Yes, sir. Actually, it should have a multidisciplinary approach, which is not always happening nowadays. Maybe not nowadays, it is not happening always. The physical medicine department has a very important role to play in our management of leprosy, especially with the care of hands and feet, as well as providing footwear and many other things. And regarding management of neuritis, even if there is no neuropathy, they have a lot to offer to the patient, even without any deficit. And the second would be ophthalmology department whenever there is an ophthalmological involvement. And I think the more important role is for the general practitioners, who should be having a high degree of suspicion for finding out cases, because it comes to dermatology only when somebody refers suspecting it as a case of leprosy. So that is the most important thing I have, I think.
Thank you. Dr. Dinesh, can you just elaborate a little more on what are actually currently available from the physical medicine side? What are things are offered by the physical medicine departments of our institutions? In which all way it can benefit the patients? A few things.
Yes, actually, one thing is regarding if there is a weakness of the muscle, etc. They will actually the updates regarding the exercises, etc. for weakness of the muscles. Second, the splints. They provide splints like knuckle bender or that, and also in our we have got wax bath also. If there is the joint problem, etc. We have got wax bath. They are doing it. So I think mainly it is the exercise, strengthening exercise. That is also that should be, I think, very well conveyed to the patient, and they should follow it. It has got a lot of importance in management of this.
Okay, what about the surgical correction of deformities? Is it possible in our setup? There could be patients who may need it, but are they getting it, or no? Is it something where we can improve a little more?
I think we can improve. I think it is not actively done in our institution, but I think that can be done with the help of surgeons, the plastic surgeons, or even orthopedicians who are interested in this field. I think this claw hand or the torsos, etc.
We had a plastic surgeon in Nuranad Hospital. Who was working there and who was doing practically everything mentioned in plastic surgery for the patients of leprosy there. I think, but he is no longer working there. I think he's moved to another country currently. But I think, if I am not sure, but if among the participants of today's program, this is something that we need all together to, what you say, to go the last mile in leprosy. Now we are in the last mile of leprosy. It's always said that the last mile is the longest mile. So we have a lot of work and lot of inputs are needed from several specialists. So that is the message I think we would like to convey in general. Can I ask one question, Dr. Binesh? You mentioned about the vaccines, the MIP vaccines. So is it available now? Where do you use it? Which people can benefit? Something more. We have not actually, most people have not used much about it. It will improve so that we can consider whether we can use it in a few needy patients. So you can tell 1 minute on that topic.
Actually, it is available, but I have to say that it is not that freely available now. I think so. And initially, that MIP vaccine, the name was Immuvac, and later it was Lapra, etc. Now I think they are promoting it as another brand. It is Sepsivac. Cadila is manufacturing that vaccine.
It's available in our market itself.
It's available, sir. Actually, I have contacted the person also. It's available, but now they are promoting it mainly for sepsis. The cytokine storm, etc. They are promoting it. Their monologue is for that only.
Yeah, probably there are more patients, in that.
Maybe. Actually, I think it was not utilized when it was introduced in I think it was in 90s. It was introduced in India. It was not that much utilized by, I think, for ST patients. That could be the reason.
One thing is that it has not, the trials, took a long time, and it has not still come in the recommendation from the NLEP side. That is why it is mostly even tried by, even now tried mostly by academicians. Does not become part of the recommendations and program. Only when that happens, only it will be taken up in a major way. And because of the cost also, I'm not sure. Is it the reason why they are not making it part of the public program?
That's actually initially the cost was actually 600 only, but now the cost is for 1 vial. It is about 8,000, I think, nearly 8,000. Okay. But 1 vial can be used for 3 or 4 patients.
What is the advantage for leprosy patients? Which leprosy patients will benefit? Which patients?
Usually the tuberculin negative type. I mean that multibacillary type of patients. We can reduce the incidence of reactions and also the transmission.
It's not a substitute for therapy. You give the proper therapy to improve the response to therapy, to make make them smear negative faster and have a better clinical outcome. You can add on to this, add on to the treatment, the MIP vaccine, isn't it? That is one.
Yes.
Does it have any role in actual primary prevention? Can it be given to contacts like that? Is there any mention?
It can be. It has got a role. Actually, when it has been proved that when it is given to the contacts, then it showed the maximum efficacy. I think actually the efficacy was almost similar when it was given to patients and contacts. or when contacts alone. Actually, there is not much that difference. Actually, that efficacy is almost.
But most of these are studies and trials, and they just not come as part of a program. Probably only then we may be able to use it in a proper way. So can Ashwini tell something about that single dose rifampicin? There are pulmonologists here, so who may have some other views on this single dose rifampicin. So can you tell something? What are the precautions? What are the flip side of a single dose rifampicin?
So actually, single dose rifampicin, 600 milligram single dose rifampicin was introduced by WHO in its 2018 guideline, and it was actually introduced for close contacts. But for a country like India, where we have a lot of TB cases as well as a lot of social stigma associated with leprosy, the practical use of this is we are not very sure about that, because when you want to give single dose rifampicin to close contacts, first of all, we have to ascertain who are the close contacts. It may not be just the family members, it may be people who are working with the person or mingling with the person. And when you want to give a drug to the contacts, you have to disclose the diagnosis of the patient to the those who you are planning to give the prophylaxis. So that is one hurdle. Second thing, TB, we are using rifampicin. So we have to screen the patients and make sure that they don't have TB or active leprosy before going in for a single dose rifampicin therapy. So that is again another problem. And another thing, the efficacy of or the protection of single dose rifampicin is said to last only for around 2 years. So again, that adds on to the problem. So we don't know how far this will be practically possible in a country like India.
Okay. I find Dr. Murali in this.
Yes, sir.
Yeah, would you like to have a quick word about it?
Pardon?
Would you like to have a quick word about this? Actually, it is already in practice. It's being done by in the health service. It is already there.
Yeah, sir. The TB is more prevalent than leprosy, and as the previous speaker said, that we have to rule out the active pulmonary tuberculosis and ideally the latent TB as well, because we may be making a treatable TB to resistant TB. So that is the only fear that I have.
That is a fear that has been shared by everyone. Yeah. But I think these programs, some of them this part people want to.
Fortunately, I have never come across with any such tuberculosis along with the leprosy. It's extremely rare, I guess.
Yeah, probably because leprosy is also not that prevalent nowadays.
So we are justified in giving rifampicin prophylaxis.
Okay, thank you. So I don't find any other questions in the chat box. So if anyone would like to unmute and ask a question, you are welcome. Provided our organizers agree, can have 1 or 2 questions.
Of course, sir. Of course, sir.
So anyone would like to unmute and ask any question or add a comment, you are welcome. Dr. Jain, would you like to? We are talking about the importance of eyes. Eye deformities, how to look for them. Probably it must be rare for you, isn't it? You may not be finding.
Yeah, actually, we are not seeing much cases nowadays, actually, but definitely it does not lose its significance. Definitely, we should all be aware that such things can happen in our day-to-day practice. But luckily for us, not seeing much cases now.
But now the thing is that we have to ensure that nobody has any of these things, because by 2030, our aim is to have none of this. So we have to totally. That is why we are keen on each and every finer aspects about every patient. Then only that can be achieved. Okay. So any other questions? Anyone? Any comments?
Dr. Rania has asked in the definition of close contacts.
Okay. Dr. Ashwini, would you like to take up that question? Who are the close contacts who will be treated by the single dose rifampicin?
Actually, I'm not sure about that. I think it is again a vague terminology. I don't know whether they have defined it. We need
Dr. Binish.
Yeah, actually, I think it's a many close contact. We mean the household contacts mainly. And the other thing, definition, I don't know actually.
Practically, what they do is that they even go to the neighboring area of within a specified distance. I forgot the distance. It's 50 meters or 100 meters, and they find out everyone from that. Someone from health system may be able to, because they are actually started doing it. So that is what they do. So they are all examined, but the problem is then the issues of privacy, confidentiality, especially in a disease with leprosy. You know, if without telling the reason, people may go and look for all these tuberculosis and leprosy, but then somebody will somehow find out the reason. Where is the index case? So that can affect the entire program. So that is a problem there. But I think it is there in the program. Okay. Any other question? Any other? Okay, I think if there are no more questions, I think I can assume that we had a fruitful discussion, which actually covered the real things that are to be known about leprosy at the current point of time. It was not too theoretical, but more practical. What are the things that can be done? What should we do to achieve our, this is again one of our sustainable development goals, one of the important SDGs, and leprosy has been picked up, I think, as the number one thing, because that is something which is feasible, because now itself we already have a good program and we have achieved a lot. So the SDG has identified leprosy as to be probably the first disease where it can do something, attain the SDG goal. So if there are no other questions, I think I will hand over to the.
Thank you, sir. Thank you, sir. Now I would like to invite Dr. Jane Chiman, Central Working Committee member of IMA, for a short address. Dr. Jane Chiman.
Thank you, Shamila. Actually, it was an excellent talk. I could join a little late, but definitely I could enjoyed. Clinical session I attended fully. It is congratulations again to Thrissur IMA for coming out with such relevant topics. I hope we have already covered, discussed about the IMA membership. Actually, IMA state and national IMA has come out with a almost 40% reduction in IMA membership. So since many medical college faculty is here, I would like to stress on new members becoming, new doctors becoming IMA members. Recently, we had a sudden death of a promising young urologist, but now Urology Association is collecting money to support his family. We all know he is just hardly in his late 30s. So we all know we have passed to that stage. We will be struggling. We won't have that much an asset at that age. But I checked, and he had not joined any of our social security schemes. If he had joined any of the social security schemes, definitely, if he had joined all the 3 schemes, definitely would have got his family would have got 1 crore. But now Urology Association is collecting some amount to support his family. But how much can they collect? If only thing all our juniors can join any of these schemes, and then definitely it will be a great help for their family. So this IMA membership and the membership in schemes should be propagated among all the new fresh graduates, because this is a great offer that IMA Kerala and also National IMA is giving, almost 40% reduction, and Thrissur IMA has come forward waiving of their branch fund for this young medical graduates. So I think this message should reach all the fresh graduates. So thank you once again for inviting me. Thank you.
Thank you, Dr. Jane Chiman.
Now I invite Dr. Shirmala PM, Joint Secretary, IMA Thrissur for the.
Thank you, Chancellor. I would like to start by thanking our President, Dr. Joy Manila, sir, and Dr. Jane Chiman, sir, and other senior members of the IMA for making this possible. Thank you, Dr. P.S. Unnikrishnan, President, Dermatology Club Thrissur, who made it here despite other pressing urgencies. Today, we were blessed to have as our moderator, Dr. Ashokan N, who was honored recently by the National Association of Dermatologists, IADVL, with a National Oration Award. Thank you, sir. Today, we had Dr. Ashwini R, who spoke on the introduction and clinical features, and Dr. Binesh VG, who spoke on the diagnosis, treatment, and prevention of Hansen's disease. They did their jobs too well. Thank you so much. Thank you, Dermatology Club, and for joining hands with IMA Thrissur and making the CME a wonderful success. Also, thank you to all the doctors of IMA who put aside their works to attend this meeting. Though I couldn't make out who it was, someone did say that IMA Thrissur comes up with interesting topics. Thank you, sir. Thank you for that honest appreciation. We will be coming up with more such CMEs and we will keep you updated. Good night.
You missed a dermatology department, Government Medical College. They also joined with us today's program.
All right. Oh, sir.
No problem.
Yeah.
Okay.
That's all right.
Thank you. Good night.
I think that comment, the compliment to IMA Thrissur was by Dr. Babu KV.
Okay, okay, sir.
From Payyanur. Okay.
Okay. Thank you, sir.
And with the team that you are having, I'm sure it is bound to happen again and again. So we are going to have extremely interesting topics on all subjects of medicine.
Yes, sir. With Joy sir as the captain of our ship, we are bound to have very good topics in the future.
Okay. Thank you all. Thank you.
Thank you, sir.
Hello.
The meeting is closed.
Ganeshan,
Close.
Hello. I have to say a few words. Dr.
Okay,
Magila,
please.
very high.
Sorry.
I was keenly observing the entire sessions. It was very wonderful. This very far better than the previous one, which I was the faculty. See the difference of the teaching faculty taking classes. You have to appreciate that. Okay. I again congratulate Dr. Manila, who know the difficulties of us and always ready to organize and compensate what are the problems we have and make this program success. Thank you very much. And also thanks the Thrissur Medical College team and Dr. Ashwini from Kottayam. Excellent speech. Okay, thank you. Congratulations.
Thank you, Dr. Nikrishnan. I have been backed by a strong companion from Thrissur. Okay, the meeting is closed. Thank you very much and good night.